Welcome to the debate. In almost every area of medicine, the definition of a patient is, well, it's a biological absolute.
Right. It's a guaranteed state of being.
Exactly. Someone walks through the clinic doors or, is wheeled into the emergency room, and clinical duty instantly snaps into place. We don't sit around questioning if the person in the trauma bay qualifies as a patient.
No, the sheer biological reality dictates that they do.
Right, but what happens when that potential patient is a previable fetus? Do those same duties exist inherently, or does the pregnant woman alone decide if there is a patient at all?
It is easily one of the most profound ethical thresholds in modern medical practice. Because suddenly that undeniable absolute it dissolves.
It really does.
We are stepping into a space where definitions are intensely contested. And we're grounding our discussion today in the 2026 Integrated Master Reference on Foundations of Medical Ethics and Professionalism.
Right. And the central question we are unpacking from the material is quite striking. Should the status of the previable fetus, that is, a fetus that hasn't yet reached the stage where it can survive outside the womb, typically around 22 to 24 weeks, be determined solely by the pregnant woman's autonomous intention to continue the pregnancy?
Or do independent clinical, ethical, and, cultural frameworks demand that we recognize an inherent status that exists entirely independent of her conferral?
It's essentially a question of whether patient status is built into the biology or if it has to be granted by the person carrying that biology. I take a firm stance on what is known in the text as the professional responsibility model. Basically, my position is that previable patient status is conferred entirely by the pregnant person's autonomous choice, period.
Entirely by choice.
Yes. There is no independent clinical, legal, or biological standard that bypasses or overrides the pregnant woman's stated intention.
And I approach this from a fundamentally different direction. I am arguing that relying purely on maternal intention is frankly a highly constrained way of viewing human life.
Constrained how?
Well, it overlooks the rich complexities of relational care ethics. It ignores deeply rooted cross-cultural realities, and, it dismisses the independent moral weight of the developing fetus, a weight that clinicians on the ground clearly recognize and struggle with every day.
Let's lay out why the professional responsibility model is the standard adopted by major bodies like the International Federation of Gynecology and Obstetrics, or FIGO. The foundational premise here is that before viability, the fetal patient is a clinically derived ethical concept.
Right.
It is not some metaphysical absolute. The fetus becomes a second patient under one condition and one condition only: the pregnant woman's autonomous decision to confer that status. If she intends to continue the pregnancy, the clinical duties of beneficence, meaning the duty to provide beneficial medical care, they snap on.
And if she doesn't?
If she does not intend to continue, they do not activate.
It makes it sound almost like flipping a switch.
Because ethically, it has to be a switch. The American College of Obstetricians and Gynecologists strictly dictates that a pregnant woman's autonomy allows her to refuse medical intervention.
Even if that refusal is likely to result in fetal harm.
Exactly. Even if it results in fetal harm or death. This intention-only framework is really the only evidence-based firewall we have to protect against paternalism. It prevents what ethicists call fetal rights reductionism.
Right, the historical practice of treating the mother as just a vessel.
Yes, the very dangerous practice of inappropriately reducing the pregnant woman to a mere vessel for fetal development.
I absolutely agree that protecting against paternalism is paramount. But, and this is a big but, if you are listening to this and wondering how a doctor can just logically switch off their duty to a biological entity, well, that is exactly the friction point we are hitting here.
Okay, explain that friction.
Reducing the previable fetus solely to a construct of one individual's stated intention is philosophically fragile. It assumes human life only has value when someone else signs a permission slip. I look toward care ethics, an approach that argues moral obligations arise from relationships of care and dependency.
But that dependency is entirely reliant on the pregnant woman's body.
True, but a developing fetus is uniquely dependent. That relationship exists biologically and ethically, regardless of stated intent. Furthermore, recent empirical studies looking at maternal-fetal medicine trainees document staggering rates of moral distress.
Right, the 2025 data by Ding et al.
Yes. Why are they distressed? Because they physically perceive a patient in front of them. The biological reality exerts a weight that intention alone cannot erase.
I hear the moral distress argument, and we will absolutely dig into what is happening with those clinicians. But first, let's look at the clinical reality versus this idea of relational conferral.
Okay.
If you look at surveys of clinicians working on the ground, like the Campo-Engelstein and Andaya data, the data shows that viability, that 22 to 24-week biological threshold, where survival outside the womb is possible, and the mother's state-A relationality are the exact criteria clinicians actively use to determine fetal moral status.
But not inherent sentience?
Right. It is not based on some inherent sentience. Let me offer a practical analogy using Cassuire, basically using past clear-cut ethical cases to solve new complex ones. Think about organ donation.
All right, let's walk through that.
A living organ, a kidney for instance, only becomes a transplant through the explicit, ongoing consent of the donor. Until that explicit intention is formalized and maintained by the sovereign individual, it is just biological tissue functioning within their body. The surgeon doesn't have an independent duty to the kidney. In exactly the same way, a pre-viable fetus only enters the clinical space as a second patient through the pregnant person's explicit intention to create that status. Without her consent, it does not hold independent standing.
That is a very common analogy in these debates, but it fundamentally breaks down on the biology. A kidney is just a kidney.
How was it different in an ethical framework, though?
Because it does not possess an active developmental trajectory toward becoming an independent human being. The fetus does. A kidney's function is static. A fetus is dynamic. Comparing the fetus to static tissue strips away the entire biological context of gestation.
I don't think it strips it away. It just...
Well, setting the biology aside for a second, my deeper concern with your framework is the sheer instability of intention as a clinical metric.
How is it unstable? It is explicitly communicated by the patient.
Because human intention is incredibly fluid, especially in high-stakes medical emergencies. Let's walk through a clinical scenario. A pregnant patient arrives at the emergency room at 23 weeks. She is in a state of severe crisis, perhaps facing a massive hemorrhage or severe preeclampsia.
Okay. A terrifying situation.
Exactly. She is terrified, in pain, and deeply ambivalent. Over a 48-hour period in the ICU, her stated intention might fluctuate drastically depending on her pain levels, her conversations with her family, or, just her fear of the outcome.
Right.
What happens to our ethical obligations then? Does the pre-viable fetus flicker in and out of patient status hour by hour? Does the clinician's duty of beneficence to the fetus blink on and off like a neon sign depending on what the mother said during morning rounds versus evening rounds?
That is a harrowing scenario, but the fluctuation of human emotion during a medical crisis is exactly why intention must remain the sole anchor. If a patient is ambivalent, the physician's duty doesn't default to assuming the fetus is a patient.
It doesn't?
No. The duty is to engage in structured, non-directive counseling. It's about respectful persuasion that preserves the woman's agency while she processes her crisis. But until she lands on a definitive intention to confer status, you cannot arbitrarily assign patient status to that pre-viable fetus.
Even if the clinical team is standing there looking at a 23-week fetus on a monitor with a beating heart, knowing they could potentially intervene?
Yes, because the moment you declare that the fetus has an independent clinical status despite the pregnant woman's ambivalence, you have just laid the ethical groundwork to override her choices.
I wouldn't say override.
You have established a competing clinical interest inside her own body. That is incredibly dangerous. If her intention flickers, the physician's job is to stabilize her and support her decision-making process. The physician cannot bypass her confusion by saying, well, since you're unsure, I'm going to act as if the fetus is a full patient and start making interventions based on that assumption.
But we know that clinicians actively recognize a status beyond just maternal intention.
And the proof of that isn't theoretical. It is the staggering level of moral distress documented in the field.
You're talking about the Ernst et al. Studies?
Yes, exactly. When we look at studies of maternal-fetal medicine fellows and neonatal nurses navigating that exact 23-week periviable gray zone, they report profound psychological distress. Moral distress occurs very specifically when a clinician knows the ethically correct action to take, but is institutionally or legally barred from taking it.
Well, they are distressed because it's a tragic situation, naturally.
It is more than just tragedy, though. It proves empirically that clinicians recognize a foundational duty of non-maleficence, a duty to do no harm, to the pre-viable fetus, and they feel that duty exists entirely independently of maternal intention.
But that feeling doesn't necessarily dictate the ethical framework.
If the fetus were merely a null entity, just tissue, until the mother explicitly conferred status upon it, this deep moral distress wouldn't exist across hospital staff. Step into the shoes of the neonatal nurse. They wouldn't feel they were violating a duty to a patient if they didn't inherently perceive a patient there. The intention-only model essentially asks these professionals to suppress their own moral intuition and pretend they don't see what they are looking at.
I think you are misdiagnosing the root cause of the moral distress in those wards. The distress absolutely exists, but look at the environment those clinicians are operating in.
The hospital environment?
The legal environment. They are functioning in incredibly restrictive legal environments, particularly in the post-Dobbs landscape in the United States. The distress stems from the fact that they are trapped by systemic barriers, shifting hospital policies, and statutory mandates that threaten their medical licenses.
That's certainly a huge factor right now.
They are agonizing over state laws dictating their practice, not suffering from a flaw in the professional responsibility model itself.
I agree the legal landscape exacerbates the distress, absolutely. But the studies on moral distress in periviable care existed long before recent legal shifts. The distress comes from the clinical act itself.
Let me push back on that, because if you indulge this idea of an independent clinical standard for the previable fetus to alleviate the clinician's distress, you inevitably slide toward compelled obstetrics.
That's a slippery slope argument.
It's historical precedent. When you start legally or clinically separating the fetus from the pregnant woman's intention, you get harmful stereotyping. The International Federation of Gynecology and Obstetrics, FIGO, actually has a specific guideline on this, drawing on international human rights frameworks.
Guideline 015, right. The guidelines on stereotyping women.
Exactly. It classifies the harmful stereotyping of women as a severe ethical violation. This includes viewing women primarily through their predestination to motherhood or assuming they have a diminished capacity for moral judgment just because they are pregnant.
I completely agree. That's a violation.
But by demanding that the fetus has an independent status before viability, you are functionally telling the pregnant woman that her moral reasoning about her own body and her own pregnancy is secondary to an external biological metric. Under CEDAW Article 5, that is the very definition of a human rights violation.
I agree completely that paternalism and stereotyping are profound ethical violations. We should never view a woman merely as a vessel. But acknowledging the moral weight of a previable fetus does not inherently reduce the mother to a vessel.
It creates a competing interest, though.
That is a false dichotomy. We can hold profound respect for maternal autonomy while still acknowledging that the fetus has moral significance. And this brings us to a massive blind spot in the intention-only framework, which is its assumption of universality.
How so? The principles of autonomy and beneficence are widely utilized globally.
Widely utilized in Western autonomy-centered paradigms, yes. But let's look globally. If we introduce the legal and ethical standards of the Gulf Cooperation Council, the GCC, and countries like Qatar, we see a completely different yet highly rigorous bioethical structure and practice.
You're referring to Islamic bioethics.
Yes. Islamic jurisprudence, or fiqh, widely recognizes ensoulment at exactly 120 days of gestation. This is the majority view in the Hanafi school of thought.
Which establishes a theological timeline.
It is theological, but it translates directly into a strict biological and temporal milestone for moral status in their medical ethics. Once that 120-day marker is reached, the pre-viable fetus has an established moral weight that operates completely independently of the mother's autonomous intention.
Right.
It doesn't require her to confer status. The status simply arrives as a fact of development. And analyses by scholars like Pluckinger and Alga explicitly confirm that Western autonomy-centric paradigms are not universally accepted. To say that a pregnant woman's intention is the absolute only valid metric for patient status is to dismiss the rigorous bioethical frameworks guiding the care of millions of people globally.
I deeply value cross-cultural dialogue, and it's fascinating to see how different frameworks intersect. The master reference we are using actually notes the overlap between Western medical ethics and the higher objectives of Islamic law, the Maqasid al-Sharia.
Exactly, there is common ground.
There is. For instance, the concept of public interest or welfare in those frameworks maps quite well onto our concept of beneficence. However, within a pluralistic, globalized clinical setting, where a single hospital might treat patients from 50 different cultural backgrounds, principalism remains the dominant and safest scaffold for a reason.
Because it prioritizes the individual's choice above all else.
Because it protects the vulnerable individual from the state. If you revert to rigid biological milestones prior to viability, like a 120-day ensoulment marker or a heartbeat bill, or any other fixed timeline, you create a system where the state or the hospital institution can mandate care against a patient's will.
But that's...
We have seen the catastrophic results of this. When institutions use independent biological milestones to assert institutional conscientious objection, it severely harms patients.
But acknowledging moral status doesn't automatically equal state mandates.
In practice, it almost always does. Look at the jurisprudence from the European Court of Human Rights. We've seen cases like RRV Poland, which repeatedly ruled that when states or institutions obstruct patient access based on these independent moral milestones, it violates fundamental human rights.
Obstructing access is wrong, yes.
Right. If the clinician says, well, it's past 120 days, so the fetus is now my patient regardless of what you want, the pregnant woman's bodily autonomy is entirely compromised. The intention-only model prevents the hospital from weaponizing biology against the patient.
That is a very valid concern regarding state overreach. The history of compelled obstructics is dark and should never be repeated. But I think you are conflating individual ethical recognition with state-mandated coercion.
I don't think I am. They are intrinsically linked in practice.
Recognizing that a 20-week fetus has moral status does not automatically mean we must chain a woman to a hospital bed and force her to endure interventions. Medical ethics uses an ethics as a toolbox approach. It allows us to hold two complex truths at the exact same time.
Which truths?
We can firmly reject coercive legal interventions, while simultaneously acknowledging that the fetus is not ethically inert simply because the mother hasn't signed a metaphorical permission slip. We talked about casuistry earlier, the legal precedents. Look at the famous cases rejecting compelled cesareans.
Like in re AC.
Exactly. I completely agree with those rulings. A competent patient has the absolute right to refuse surgery. But you can believe a patient has the right to refuse a cesarean while still recognizing that the fetus that dies as a result was a patient to whom we owed a degree of moral sorrow and distress. The intention-only model sanitizes the gritty, heartbreaking reality of pregnancy. It pretends the second patient simply blinks out of existence if the mother withdraws intention.
It doesn't sanitize the reality. It clarifies the professional obligation so the clinician knows exactly how to act. Medical ethics isn't just about feeling sorrow. It has to be operational on the clinical floor.
Operational, yes, but not reductive.
But if we accept your premise that the previable fetus has an independent moral status, but we also agree that we cannot legally or physically coerce the pregnant woman, what exactly is the clinician supposed to do with that independent status?
They acknowledge the tragedy of conflicting duties.
But clinically, what is the action? If there is no actionable clinical pathway, then assigning independent status merely becomes a mechanism for generating guilt and moral distress.
Not guilt. Recognition of a loss.
The professional responsibility model solves this paralyzing dilemma by stating clearly, your beneficence obligations to the previable fetus are entirely dependent on the woman's conferral. If she withdraws it, your primary duty snaps back entirely to her autonomy and your duty to do no harm to her. This prevents the clinician from falling into the trap of becoming an antagonist to their own patient. It keeps the therapeutic alliance intact.
But we know that the clinician does experience that conflict, whether your model formally allows for it or not. You are trying to engineer away a profound moral complexity by definitional fiats.
It's about providing a safe framework, not engineering away complexity.
But by simply defining the previable fetus as a non-patient on paper, you are asking clinicians to ignore the empirical reality of the care they are providing. The web of relationships, the sheer biological dependency of the fetus, and the profound nature of human gestation cannot be neatly categorized into a sterilized intention contract. It does a disservice to the gravity of what is happening in those hospital rooms.
I understand that it feels reductive to some, but let me map what that intention contract actually achieves in the real world as we look to summarize our debate today. My stance is that anchoring previable fetal status solely in maternal intention is fundamentally protective.
Protective of the mother, yes.
It acts as an evidence-based firewall. The very moment you introduce an independent clinical, legal, or biological standard for the previable fetus, you provide a wedge, and historically, that wedge is always used to introduce systemic bias, paternalism, and the erosion of bodily autonomy.
Right, but
The master reference reminds us that pregnancy does not diminish a patient's decisional capacity. The fetus absolutely acquires independent clinical weight at viability, but before that threshold, relying strictly on the pregnant woman's autonomy is the only way to ensure medical care remains patient-centered and utterly free from coercion.
And my summary is that while maternal autonomy is absolutely foundational to modern medicine, reducing the previable fetus purely to a construct of stated intention is philosophically hollow.
Hollow.
Yes. It ignores the complex web of care ethics. It dismisses the realities of cultural and religious bioethics globally. Most importantly, it waves away the legitimate moral weight recognized by frontline clinicians who suffer genuine distress when navigating these impossible cases. We can protect women from coercion without pretending the previable fetus is ethically meaningless until chosen. The clinical reality requires a more nuanced toolbox than simply waiting for a declaration of intention.
We do find significant points of convergence in the source material, though. Both of us and the ethical frameworks we've explored agree completely that post-viability, once we cross that 22 to 24-week biological threshold where survival is possible, independent beneficence obligations to the fetal patient firmly and undeniably activate.
Absolutely. At viability, the biological reality and the ethical frameworks align. The duties to the fetal patient become undeniable, and we both categorically reject coercive legal interventions. Court-ordered cesareans, forced blood transfusions, and state-mandated physical interventions against a competent pregnant person's will are severe ethical failures regardless of the gestational age.
Which leaves us to reflect on the enduring tension of the maternal-fetal dyad. We started out by talking about the clinic doors, how in most of medicine, simply crossing that threshold guarantees your status as a patient. But in prenatal medicine, the threshold is not a simple door.
No, it's not.
It is the complex, deeply human reality of two interconnected lives.
It is a totally unique landscape where multiple ethical frameworks must somehow find a way to coexist. The clinical realities, the legal precedents, the global cultural views, and the deeply personal stakes all collide right there in the consultation room.
And there is so much more to explore in the 2026 Integrated Master Reference on these exact moral questions. The boundary lines of patient status will likely always be contested, leaving us to navigate the incredibly delicate space between biological certainty and human autonomy.